Teacher Toolkit to Promote Well-Being in Students with Epilepsy. Part 3. How to Administer Emergency Medications to Students with Epilepsy. Funding for this teacher toolkit was provided by the Ontario Trillium Foundation through their GROW grant stream. The grant will support the development of resources for parents and teachers. Working together, parents, teachers, healthcare providers, and community epilepsy agencies can support children with epilepsy so that they can make positive and healthy choices, both now and in the future. Epilepsy, diabetes, asthma, and anaphylaxis have all been recognized as prevalent medical conditions affecting children in Ontario schools. These conditions were identified because they can all result in a medical incident or a life-threatening medical emergency. This is Part 3 in the Teacher Toolkit. To view Part 1 and Part 2, kindly go to our website at www.schooltocommunity.ca. Part 1. Epilepsy and Seizure First Aid. Part 2. The Cognitive, Psychological, and Social Consequences of Epilepsy. Part 3. How to Administer Emergency Medications to Students with Epilepsy. An interview with Dr. Andrea Andrade, Director of the Pediatric Epilepsy Program at London Health Sciences Centre and Medical Advisor at Epilepsy Southwestern Ontario. Do you need to be a healthcare provider to administer rescue medications to children with epilepsy?
No, you don't. We prescribe rescue medication or emergency medication to parents all the time. Parents who are not healthcare providers, and they are very simple to administer and it's very simple to use. If you think about other comparable situations, this would be comparable to the EpiPen. So if the patient has an anaphylaxis randomly in the streets, anybody can just grab the EpiPen, administer it, and save somebody's life.
When do you prescribe emergency medications to children with epilepsy?
Typically, we prescribe emergency medications when there's a history of prolonged convulsive seizures, meaning that the seizure may last longer than 5 minutes and may affect respiration, the breathing pattern of the body, and so on. When seizures go very prolonged, they start affecting our ability to breathe, our ability to swallow and protect our lungs from secretions to go in the wrong direction, and certainly that can affect vital organs. Patients that go in very prolonged seizures, they tend to require intensive care unit admissions. They may require a tube to breathe and monitors to make sure their heart is fine, and so on. It's very important to treat them very soon because that decreases that risk. So the tragic situation that can put the child in a high risk if the teacher or any parent or coach decides to do nothing in the case of a child goes beyond the 5-minute point mark when a seizure is happening.
We asked Dr. Andrade to describe what is happening during this generalized tonic-clonic seizure.
This is an example of a convulsive or a motor seizure. So just notice how there is a twitching component of the body of the child, affecting more so the right side. There's also some posturing going on. So there's the tonic component or the stiffening of the body. And then there's this aggressive motion of both arms. Remember, it's not just the legs and the arms that are getting stiff and twitchy. It's also the mouth and the tongue and the throat muscles that are producing increased secretions, increased salivation. That's why it's increasingly important to put the child on the side so their secretions can go outside the mouth.
Why are prolonged convulsive seizures a medical emergency?
The problem with convulsive seizures is that they may have twitching of the body or stiffening of the body, but not only to the limbs or the head. It also implies a stiffening of the muscles of the throat, so that can cause difficulty breathing. It can cause also stiffening of the muscles of the thorax and the abdomen, so that can cause the patient to vomit or to excrete secretions from the mouth. So those are the typical seizures that we treat when they go beyond 5 minutes, and those are the typical seizures that may tend to go into status epilepticus, or what we understand of a very prolonged seizure that require help with breathing and so forth. The problem with not giving medication is that if we leave a patient seizing for more than 5 minutes, the odds that that seizure keeps going for a longer period of time is higher, and certainly seizures that go for that long may not only be a very severe stressor for the patient, but also can affect their ability to breathe and their ability to swallow, and can put the patient in a greater risk of requiring intensive care unit care, and perhaps even put the life of the child at risk.
What are the different types of rescue medications for students with epilepsy? Most children will have a prescription for a pill called lorazepam, commonly known as Ativan. This is a dissolvable pill that is placed in the mouth. The medication works quickly because it doesn't absorb in the stomach where it needs to be digested. A minority will have a prescription for an intranasal lorazepam that is sprayed into the nostrils. A minority will have a vagus nerve stimulation device. What is the difference between administering lorazepam sublingually or in the buccal cavity?
So in the strict sense of administering medication, sublingual means that the medication should go underneath the tongue. And buccal means that it can go to the side of the tongue. In reality, the mouth is a very vascular cavity with a lot of blood vessels, so the absorption of the medication goes as fast as sublingual and as fast as buccal. In patients with epilepsy, we prefer the buccal administration because, remember, there's a stiffening component. So majority of those patients are going to have a very stiffened jaw and clench their teeth. So it's going to be very difficult to open their mouth and try to administer sublingual. So forget about that, just do it buccal.
What are the risks of administering rescue medication to children with epilepsy?
They are not really a risk. The patient is going to be sedated after the medication is administered, but anyways, the patient after a seizure stops is going to be sedated anyways. In the overall risk balance situation, it's more risky not to do it than to do it. Not to do it can put the child in risk of an ongoing, very prolonged seizure that may affect their breathing or their heart function. The bigger risk is when the teacher does nothing.
Should a teacher be worried that they will be bitten by the child when they are administering rescue medication in the mouth?
If they give it properly, it's not really a risk, because they are not going to open or try to open the jaw. They are going to just pull the cheek on the side and squeeze the pill. Typically, these children, as we mentioned, they have the jaw very clenched. It's difficult to open. They are not going to open and bite, and they just have to squeeze the pill in between the cheek and the gum and put it in there. In my experience, there's no risk for biting if they do it that way.
How do teachers administer rescue medications at school?
Start counting the time as soon as possible, and once the clock reaches the 5-minute mark, then get the medication, get the pill out of the bottle with your finger, pull the cheek of the child out, and then stick the pill in between the gum and the cheek. Put some pressure in the cheek and wait for a few seconds to get it dissolved.
This is a reenactment to demonstrate administering rescue medication. Step 1. Time the seizure. Step 2. Once it reaches the 5-minute mark, get the medication. Step 3. Get the pill out of the bottle. Step 4. Place the pill in between the gum and cheek. Step 5. Place pressure on the cheek and wait until dissolved. How fast-acting is the rescue medication?
This is what we call a rapid benzodiazepine, or a rapid rescue medication. So as soon as the medication starts dissolving in the cheek, it will take few seconds, around 30 seconds approximately, to start decreasing the seizure intensity.
What is vagus nerve stimulation, or VNS?
VNS is a surgically implanted device that we use in very specific group of patients with epilepsy, the ones that are very severe, that they don't typically respond to medications. The VNS is like a pacemaker, that it's a small circular device that gets implanted under the skin, typically in the left side in the upper chest. It's very easily palpable and noticeable, especially in younger children, and the device is in an on and off cycling, giving a stimulation through a nerve that crosses the neck. That produces a decrease in the seizure activity in the brain.
Some children with epilepsy may have a vagus nerve stimulator, also known as a VNS. VNS therapy consists of a device that is implanted under the skin in the left chest area. The device is programmed to deliver pulses or stimulations at regular intervals. A child does not need to do anything for this device to work. How does VNS work?
The device is pre-programmed by us in the clinic, and the device has 3 features. One is the device on its own, again, is cycling in an on and off fashion, producing a stimulation through the nerve that runs in the neck, and that decreasing the risk of seizure happening. The device also comes with a small magnet that we give to the families that can serve as a rescue approach. What they have to do is the magnet will give an extra stimulation. It's also pre-programmed to give extra stimulation by swiping across the device, and that gives the stimulation to stop the seizure when it happens.
How can a teacher support a child who has a VNS?
Typically, the teacher should know if they have in their classroom a child with VNS. They will have a letter from the provider explaining how to use it. But typically, the child will have with him or her a small, tiny magnet that it's just very simple. They grab the magnet. If the seizure happens, they just swipe the magnet across the VNS.
Can a teacher harm the child when they swipe the magnet?
No. The magnet only gives an extra stimulation, and the extra stimulation is not going to harm the child. It's just going to help the seizure to stop.
Do you have any final thoughts that you would like to share with teachers?
So we have to understand that children with epilepsy are coming to the clinics just for 1 hour every 6 months. We can give them directions and guidance and prescriptions for medications, but these children are going to go outside to their school, to their church, to their camp, to their family members, and everybody should be aware of how to manage these children in the outside the hospital setting. So, and because the children spend a great amount of time at school, teachers are a very important piece in the chain of care for these children with epilepsy. So we are certainly looking forward to a closer collaboration and a closer communication. How can we support them? And of course, how can we support us to make sure that patients with epilepsy live a lifestyle as anybody else outside the 4 walls of the hospital?